adaptive changes to unfavorable environmental conditions which may result in epigenetic changes, metabolic disorders, vascular dysfunction, neuroendocrine impairment, and renal dysfunction. These adaptations may promote several fetal survival, but increase the long-term risk of cardiovascular and renal diseases. Adverse outcomes in fetus include intrauterine growth restriction, premature birth, oligohydramnios, placental abruption, low birth weight, small gestational age, fetal distress, and death. And with respect to long-term phenotypes, with respect to manifestations in childhood and adulthood, include hypertension, cardiometabolic disease, cardiometabolic and vascular disease, obesity, dyslipidemia, type 2 diabetes, behavioral alteration, altered fertility, premature aging, osteoporosis, and kidney failure. Because of this, it's very important to implement preventive strategies to limit or reverse these adaptations and improve the long-term health. Recent studies are expanding the knowledge about the early life exposure to risk factor and blood pressure in childhood in the already mentioned periods with transgenerational implications. With respect to or regarding prenatal period, it's important to mention maternal and paternal genetic factors. There is an association of blood pressure and hypertension between parents and offspring. And you can see in this study where the risk of hypertension in children is approximately twice as high if one parent has hypertension and more than 4 times higher if both parents have hypertension compared to the control group whose parents do not have hypertension. As for maternal factors, it's important to mention hypertensive disorders of pregnancy. In this meta-analysis, this clinical condition is associated with a significant increase in BP in the range of 2 to 3 in systolic blood pressure and 1 to 2 millimeters of mercury in diastolic blood pressure in offspring exposed to maternal preeclampsia. And in this Finnish Consortium for Preeclampsia genetic study, in 182 preeclampsia versus 85 no preeclampsia children of 8 to 12 years, the mean 24-hour ABP and systolic blood pressure was higher 2.9 millimeters of mercury in preeclampsia children versus no preeclampsia children. And this difference was more pronounced in early onset compared with late onset preeclampsia. So, during childhood and young adulthood, the offspring of pregnant women with preeclampsia are at an increased risk of high BP. Regular BP monitoring in this population is essential. Continue with maternal factors such as higher prepregnancy body mass index, greater gestational weight gain, and gestational diabetes may increase the risk for hypertension in offspring. With respect to maternal obesity, in the 2022 study, they found 1.9 millimeters of mercury increase in systolic blood pressure and 0.5 millimeters of mercury increase in diastolic blood pressure of offspring with every 5 kilograms per square meters gain in maternal PP body mass index. And with respect to maternal diabetes, in this 2019 study, in a multivariate of radius among children and mothers with gestational diabetes compared with children of mothers without gestational diabetes were 2.32 for hypertension and 1.89 for high blood pressure. So, controlling maternal obesity and gestational diabetes may be important for preventing childhood hypertension in the affected offspring. With respect to maternal exposures, in the 2008 study, and early intimal alterations of the coronary arteries are detected in the prenatal and infancy periods and may be significantly associated with maternal smoking. In this 2018 study, they investigate the pregnancy exposure to air pollution, and they found that per 5 micrograms per cubic meters increase in PM2.5 during the third trimester was associated with a 3.49 percentile increase in child systolic blood pressure or a 1.47 times higher risk of elevated BP. And in an assisted reproductive technology, in the 2019 study, a systolic and diastolic 24-hour ambulatory blood pressure was significantly higher in subjects conceived through this technology, and also impaired flow-mediated dilation, increased pulse wave velocity, and intima media threadiness persist at 5 years follow-up in these subjects. So, ART induced premature vascular aging persists in apparently healthy adolescents and young adults without any other detectable classic cardiovascular risk factors and progresses to hypertension. As for maternal factors, it's important to mention maternal vascular malperfusion. In this recent study, twins whose placentas were discordant for maternal vascular malperfusion, the twin with high rate of this clinical condition had a higher systolic blood pressure, 5.7 millimeters of mercury at the age of 7. So, the findings support the role of the placenta and the intrauterine environment in the development origins of cardiovascular health. Regarding perinatal periods, low birth weight is very important, and according to epidemiological studies, Dr. Vargas, Dr. Before mentioned, according to epidemiological studies by Dr. Barker studies in 1980s, low birth weight is associated with an increased blood pressure in the Hereford's population and related to development of ischemic heart disease and infant mortality. As you can see in the data from 1944-1945, an unfavorable gestation and nutrition environment in critical periods resulted in an increased risk of cardiovascular disease. And with respect to Helsinki study, different broad lines in low birth weight according postnatal environment precede development of hypertension. So, low birth weight infants require long-term monitoring to prevent the development of hypertension. With respect to small for gestational age and premature birth, in this 2008 study proposed that lower renal mass in small for gestational age was young indicated a risk for diminished kidney function and greater salt sensitivity, as well as higher BP. So it has been proposed that kidney size and development and cardiovascular function should be monitored in youth who seem to be at risk. And in this 2020 study, ex-preterm survivors at 25 years of age had higher overall ABPM compared with controls at all time points in the post-surfactant area. So, individuals born prematurely, small for gestational age, have on average a systolic blood pressure approximately 2 to 3 millimeters of mercury higher than their full-term and normal birthweight peers. Continue with perinatal factors. In this recent study, early intermittent hypoxemia events and percentage of time with hypoxemia between 8 and 14 days of age in preterm infants were associated with hypertension. So, decreasing intermittent hypoxemia during this critical period may reduce incidence of later vascular stress in this population. Regarding postnatal periods, conditions such as obesity, suboptimal diet, insufficient physical activity, sedentary behavior, sleep disturbance, and other environmental stresses can lead to increased cardiovascular disease, manifested as vascular stiffness, cardiac hypertrophy, and hypertension. With respect to excessive catabolic and childhood obesity, in this recent study, preschool obesity, low birth weight, and excessive catabolic increase the risk of occasional hypertension in childhood, and obesity is a vital risk factor for occasional hypertension with an OR 2.93. So, small for gestational age infants should achieve moderate catabolic before the age of 2, and both appropriate and large for gestational age infants should also avoid childhood obesity to reduce the risk of hypertension. With respect to dietary factors, exclusive breastfeeding during the first 6 months of life is associated with early cardiovascular benefits. With respect to high sodium intake, There is a positive association of sodium intake with BP in childhood, with an increase in systolic blood pressure of 0.8 millimeters of mercury and in diastolic blood pressure of 0.7 millimeters of mercury with each additional gram of sodium per day, and a reduction of 1.2 millimeters of mercury in systolic blood pressure and 1.2 millimeters of mercury in diastolic blood pressure was published after the sodium reduction intervention. With respect to potassium diet, consuming more potassium-rich foods during childhood may help suppress the rise of BP in adolescence. And with respect to high consumption of sugar drinks, it is associated with an increased systolic blood pressure in adolescents too. Insufficient physical activity increases the probability of having BP by 3 times. When physical activity is regular, it produces a significant reduction in BP, both in the office measurement and in the IBPN. And after 3 months of training, the decrease in systolic blood pressure was 7 to 12 millimeters of mercury, and 2 to 7 millimeters of mercury in diastolic blood pressure. And the volume of physical activity may be more important than the intensity of physical activity. Sedentary behaviors increase the risk of developing high BP. And sleep disturbance, such as that include chronic sleep restriction, poor sleep quality, and sleep variability, are associated with increased blood pressure in adolescents. As you can see in this study, adolescents with poor sleep quality, as measured by the sleep efficiency of below or equal 85%, are 3.5 times more likely to be pre-hypertensive or hypertensive. In this slide, I want to share with you a summary of the prevention measures in population at risk of developing hypertension in all the cycle of life. It is an adapted and modified by the Lancet 2013. Excuse me. As a conclusions, early life exposure to risk factors are potentially important in the development of blood pressure in childhood. There are critical periods in which hypertension programming could be mitigated through primordial and primary preventive strategies, as well by initiating earlier treatment. So, regular blood pressure monitoring during childhood and optimizing blood pressure-related health behaviors can mitigate the risk of hypertension in childhood and decrease cardiovascular and renal morbidity and mortality later in life. Thank you very much, and I want to show you